And in that we finished chronic pancreatitis, right? So now let us talk about carcinoma pancreas. Let us know about carcinoma pancreas. Now, first of all, most common site and most common type. Most common site is head of the pancreas, and most common type is invasive ductal adenocarcinoma. Invasive ductal adenocarcinoma. Now, in carcinoma pancreas, risk factors are important for our examination point of view. In risk factors, very important point to note here is 4 malignancies, remember. 4 malignancies where smoking is the most important risk factor. So what are those 4 malignancies? Malignancies: lung, pancreas, kidney, and urinary bladder. These are the 4 malignancies: lung, pancreas, kidney, and urinary bladder. These are the 4 malignancies where smoking is the most important risk factor, remember. Then, other than smoking, there are few risk factors which we all should know, and in that, diabetes mellitus, chronic pancreatitis, hereditary pancreatitis, and important to know, Peutz-Jeghers syndrome also. And it is important for you to note further a potential question again: tall stature is also a risk factor for carcinoma pancreas. And another important point in carcinoma pancreas to note is alcohol. Alcohol has an association. Alcohol has an association with carcinoma pancreas. It is not a direct risk factor. Important point. So alcohol is not a direct risk factor. Another important point in risk factor of carcinoma pancreas is post-cholecystectomy. Important to note, there are 2 malignancy risks which gets increased. After cholecystectomy, there is increased risk of 2 malignancies. What are those 2 malignancies? One is pancreas, and second is a colorectal malignancies. 2 malignancy risk increases after cholecystectomy. One, pancreas, and second, colorectal. These are the 2 malignancies whose risk is going to get increased after cholecystectomy. Important. Then another important point, answer in your MCQ source again as a problem here. The most common gene mutation associated with carcinoma pancreas. Please, this is the latest here. The most common gene mutation associated with carcinoma of pancreas as per the latest is P16. It was KRAS earlier. It was KRAS earlier. Now it is P16. And another very important point to note, the most common gene mutation associated with carcinoma of pancreas is P16 though. Please be careful about the language of the question. The earliest gene mutation, if asked, it is KRAS. Earliest gene mutation is KRAS. Most common is P16. Okay. Then comes presentation. Most common presentation of a patient of carcinoma of pancreas. What is the most common presentation of a patient of carcinoma of pancreas? Imagine this is the duodenum. This is ampulla of Bator, and here is the malignancy. So what do you think will be the most common presentation? Shrinkage of duodenum. Patient will come to you saying that I have a shrinkage of duodenum. How will patient come? The most common presentation of a patient of carcinoma of pancreas is painless, progressive. What kind of jaundice? Obstructive jaundice. Painless, progressive jaundice. Patient can also come to us with loss of appetite. Patient can also come to us with features of goo. Patient can also come to us with features of gastric outlet obstruction, right? And very important point to note, pain in carcinoma pancreas is a late feature. Important point. Checked in exam. Pain in carcinoma pancreas is a late feature. And another important point to note is weight loss. Weight loss in a patient of carcinoma pancreas, again a question very commonly asked, is a feature of advanced disease. Weight loss in a patient of carcinoma pancreas is a feature of advanced disease, and these patients can also come to us with migratory superficial thrombophlebitis. What is migratory superficial thrombophlebitis called? Rogers syndrome. Patient can also come to us with Sister Mary Joseph nodule. Patient can also come to us with Blummer shell. What is Blummer shell? What is Blummer shell? What is Blummer shell? सुना सुना लग रहा है? It is nodularity at pouch of Douglas. Blummer shell किस ओर में था ये? कहीं तो था, कहीं था सर ये. कहाँ था ये? Carcinoma stomach. Carcinoma stomach. Then, very important point. See, this is something you have to understand, and this kind of a clinical question you may come across in exam also. देखो, ये duodenum है. Please try to appreciate these points. This is pancreas. This is the pancreatic duct and the CBD, and here lies the malignancy. Most of the time, head of the pancreas is the region where most common location of carcinoma pancreas is. So you can appreciate that there will be a compression over the CBD. Agreed? So once there is a compression over the CBD, the proximal CBD will dilate. Yes or no? Yes or no? Not only CBD will dilate, but also gallbladder will get distended, and the right and left hepatic duct also will distend. Once the obstruction is there, there will be the proximal dilatation of the biliary channel. Yes or no? So remember one basic rule. This rule they can check in your exam too. Any patient once comes to us with a feature of obstructive jaundice. Any patient once comes to us with features of obstructive jaundice. What will be the features of obstructive jaundice? How will you know that the patient has an obstructive jaundice? Jaundice में obstructive jaundice कैसे पता लगेगा? क्या फीचर ऐसी होंगी क्लिनिकली पेशेंट की जिससे हमें पता लगेगा कि पेशेंट को जॉन्डिस तो है बट वो ऑब्स्ट्रक्टिव भी है. पेशेंट ये बोलता हो तो आएगा नहीं कि मेरा अनकॉन्जुगेटेड या कॉन्जुगेटेड बिल्कुल बढ़ा हुआ है ना. ये तो हमें लैब इन्वेस्टिगेशन से ही पता लगेगा, बट क्लिनिकली हमें कैसे पता लगेगा? पेशेंट की येलोइश डिस्कलरेशन ऑफ स्क्लेरा है, ये तो किसी भी जॉन्डिस में होगी, राइट? तो अब कैसे पता लगे कि ये येलोइश डिस्कलरेशन ऑफ स्क्लेरा इज एक्चुअली बिकॉज ऑफ ऑब्स्ट्रक्शन? Very good. The clinical points which will give you the clue that probably this patient has an obstructive jaundice are these. One, there will be a change in color of the stool. What color stool the patient will have? Will have a pale color stool. Patient will have the yellow color of the stool will not be there because bile is not coming into the intestine. What else will tell you that the patient has an obstructive jaundice? Any other thing which you can think of? Urine color will be dark in any jaundice. So with urine color, you will not know. नेल्स क्या किसी और जॉन्डिस में येलो नहीं होगा? किसी में भी होगा. आई एम टॉकिंग अबाउट जॉन्डिस तो है पेशेंट को. अब हम ये जानना चाहते हैं कि ये जॉन्डिस ऑब्स्ट्रक्टिव है या नहीं है. एग्जाम्स में क्लिनिकल क्वेश्चंस आएंगे. वी हैव टू नो दिस क्लिनिकल पॉइंट्स. इफ द पेशेंट इज कंप्लेनिंग ऑफ itching is a feature which is again suggestive of obstruction. And then pain abdomen, presence of pain abdomen, but pain abdomen is not a very classical point about obstruction, because pain abdomen can also happen in hepatitis also. So pain abdomen is also a kind of a clue, but not a very confirmatory kind of a clue. But these things once there, this is a feature which is there only in obstructive jaundice. Change in color of the stool to pale and having a itching. These are the features seen in obstructive jaundice only. Now, then, when a patient comes to us, you all know we are supposed to do the examination, right? So, what clue in the examination will be there to tell us that probably there is an obstructive jaundice? So on examination, what clue will be there to tell you that probably it is obstructive jaundice. Itching will not be seen on examination. Itching is a symptom. The scratch marks will be seen on examination. Okay, conjugated bilirubin on examination, you know your fingers have analyzer. Spider navy is there in obstruction, jaundice. अभी बताया मैंने कि obstruction है. So what will you find? You will find a globular lump in the right hypochondrium, which is moving with respiration. On inspiration, it is coming down. On expiration, it is going up. So if this is there, it is clear cut that the patient has an obstructive jaundice. Now, please highlight this in your notes. A patient, listen to this carefully. सुनो पहले, समझो पहले, और फिर answer देना. There can be two reasons for obstructive jaundice. Listen to this. One reason can be benign reason. One second reason can be a malignant reason. One reason can be benign. The other reason can be malignant. There can be two reasons for obstructive jaundice. Now, can you tell me, we have already discussed it, so I want that answer from you. Can you tell me that what is the most common benign reason for obstructive jaundice? CBD? Very good. CBD stone. Right? So, most common reason for obstructive jaundice, benign reason is CBD stone. Right? And what is the most common source of CBD stone? Gallbladder. Secondary stone is the most common reason for a CBD stone. What is very important for us to know, in a patient of obstructive jaundice due to gallstone leading to CBD stone, you may have these features, but this will not be there. In case of a CBD stone causing an obstructive jaundice, the gallbladder is not distended. Gallbladder in obstructive jaundice, if found to be distended, it means there is a malignancy at the lower end of the CBD. So this is a very important point which I am telling you. So this is a very important clinical profile also. So any patient who has an obstructive jaundice, if found to have a lump in the right hypochondrium, which is moving well with respiration, the patient's chances of having malignancy lower down are very high. In an obstructive jaundice due to CBD stones, you will not get a distended gallbladder. Right? Okay. So in any given question, if you find on clinical examination gallbladder distended, think of a malignancy at the lower end of the CBD. What all malignancies at the lower end of the CBD can lead to obstructive jaundice? Can you tell me? One malignancy, I already told you, is pancreatic malignancy. Any other malignancy you can think of and make a gallbladder distended? Duodenum. Second can be a malignancy arising from the duodenum. Any other? Any other? If the malignancy itself is arising from the CBD, if the malignancy itself is arising from the CBD, what is that malignancy called? Cholangiocarcinoma. If the malignancy arising from the CBD, that is called cholangiocarcinoma, then also there will be the same profile. So that means whenever a patient of obstructive jaundice has a distended gallbladder, one should think of pancreatic cancer, cholangiocarcinoma, or a duodenal cancer. Remember. Okay. So now you all know this. So I expect an answer here. Your patient, imagine, has come to you with this profile. Imagine your patient has come to you with this profile. Okay, and this is a question asked to you in exam. The patient has come to you with a complaint of yellowish discoloration of sclera with itching all over the body. On clinical examination, there's a globular lump which is moving well with respiration. What will be your next step? We should first do, if you are in the choices, you have a lab investigations, then you will do liver function test, right? But if in your in the given choices, you have all the imagings there, what will you do? We know that, so it is ultrasound. So if the imagings are there, answer will be ultrasound. If the lab investigations are there, the answer will be LFT. Now, what LFT parameters you will get in a obstructive jaundice? Quickly, I told you. Bilirubin will be raised. What bilirubin? Now tell me. Direct bilirubin. Right? What else? ALT नहीं, ALT. कोई बालाजी फिल्म नहीं है. ALT. It is ALT. और क्या होगा? Gamma glutamyl transpeptidase will also be raised. Gamma glutamyl transpeptidase will also be raised. Right? So this way you will come to know that the patient has an obstructive jaundice now. It is now confirmed. Now in ultrasound, very important point I am telling you. Let me see who answered this question right. You did ultrasound, imagine. You did ultrasound. On ultrasound you found that there is a CVD dilated in the supraduodenal part. Listen to this carefully. The CVD is dilated up to the supraduodenal part and the diameter of the CVD is 10 mm and there are multiple stones in the gallbladder. What will be your next step? I told you that. We have discussed it. MRCP. Whenever you find on ultrasound stones in gallbladder, I told you very categorically. Whenever you find on ultrasound stones in gallbladder and the CVD is dilated, the most common reason for that is CVD stone. And in that, we have to do MRCP as a next investigation. Did I tell you? Right? And now remember, as a rule, another important rule for your clinical thing, in any patient of obstructive jaundice, if on ultrasound you find a distended gallbladder with CVD dilated, if you find distended gallbladder with CVD dilated, we know that most common reason for this is malignancy. Most common reason for this is any malignancy which can be arising from CVD, can be arising from duodenum, can be arising from pancreas. So our next investigation will be CT scan. Please be very careful about this jaundice clinical approach. You will be checked. Okay, so whenever we find a distended gallbladder on ultrasound in a patient of obstructive jaundice and the CVD is also dilated, our next investigation will always going to be CT scan because we are suspecting malignancy. We did MRCP there because we were suspecting CVD stone because the investigation of choice for CVD stone was understood now. Okay, so remember this always. Okay, now. So we were talking about a carcinoma of pancreas. Okay, so we will go ahead with this approach again in a patient of carcinoma of pancreas because the patient of carcinoma of pancreas is going to come to us with features of obstructive jaundice. right? So if we are asked what is the investigation of choice for carcinoma of pancreas, answer will be CT scan. And if I ask you, you should be able to answer this. I already told you that. What is the most sensitive investigation for carcinoma of pancreas? EUS. Very good. Endoscopic ultrasound. Endoscopic ultrasound is the most sensitive investigation. Now, what is the tumor marker for carcinoma of pancreas? CA19-9. CA19-9 is the tumor marker for carcinoma pancreas. Now, in management of carcinoma pancreas, we have the option of surgery. We have the option of chemo. We have the option of chemo. We have the option of surgery, right? Now, please understand this. This was a question already checked in your exam. In surgery, what surgery we do? The surgery done is now a modified with pulse procedure. Surgery done in carcinoma pancreas now is modified with pulse procedure. Okay, and or which is also called pylorus preserving with pulse, which is also called pylorus preserving with pulse. Now, I give you a very simple way of remembering the management of carcinoma pancreas. If you know this, which I am going to tell you, you will be able to answer any question on management of carcinoma pancreas. Okay, what is that? In any given patient, now can you tell me, let's see you answer it right again. What is the most common site of distant metastasis of carcinoma pancreas? All GI malignancies, liver. So most common site of distant metastasis from carcinoma pancreas is liver. So if in any given question you are provided that there are distant metastasis provided, or you are provided that there is a malignant ascites in any given question, or you are provided that adjacent structure involved with pancreas, any adjacent structure involved told to you, or you are told that there is a celiac artery or superior mesenteric artery invasion. In any such given situation, any of them, your answer is going to be chemotherapy with palliation of symptoms. Your answer is going to be chemotherapy with palliation of symptom. For rest all questions, your answer will be modified with pulse procedure. As simple as that. Okay. They also asked you in exam that what all structures are removed in Whipple's procedure. We should know that what all is removed in Whipple's procedure. If this is pancreas, this is the growth, what all structures are removed? See here. अभी कल तक होगा वैसे. इससे जल्दी सर्जरी हो जाए।
सर चार्जर लगा दीजिए सर। ये चार्जर
कुछ ना हुआ, चार्जर लगा दीजिए। चलो अच्छा, ये धीरे धीरे जाए, पूरा प्रोसीजर ही दिख रहा है। तो अब क्या क्या रिमूव हो गया देख लेते हैं। ये गया, तो क्या क्या निकल गया, पूरा सीबीडी, होल सीबीडी, ड्यूडेनम, ड्यूडेनम, गॉल ब्लैडर, ठीक है, पार्ट ऑफ द जेजुनम, part of the jejunum and head of the pancreas 2 centimeter from the growth, 2 centimeter from the growth, right? तो ये सब निकल गया। अब इसे ऐसा तो नहीं छोड़ सकते, we have to establish the continuity, right? So what we will do, we will do this. So what all structures are removed? CVD, duodenum, gallbladder, part of the jejunum and 2 centimeter of the pancreas away from the growth. Earlier we were removing part of the stomach also. Now we are doing a pylorus preserving Whipples. We don't remove the part of the stomach. So now it is called pylorus preserving Whipples. So after doing this Whipples procedure, how we establish the continuity, let's see. So what will this be called? क्या? अभी क्या किया मैंने? क्या reconstruction? What will this be called? Gastro, pancreatico, hepato, कुछ भी। अरे किस किस को जोड़ रहे हैं ये देखो, पैनक्रियास को जेजुनम से जोड़ रहे हैं, पैनक्रियास को जेजुनम से जोड़ेंगे तो गैस्ट्रोजेजुनोस्टमी होगी, पैनक्रियाटिको-जेजुनोस्टमी। So we have done PJ, ठीक है। अब ये क्या होगा? What will this be called? को जेजुनम से जोड़ रहे हैं तो क्या होता है? हेपेटिको-जेजुनोस्टमी। सो HJ, ये क्या होगा? अब क्या है? गैस्ट्रोजेजुनोस्टमी। So they have asked this question: what is the order of anastomosis? PJ, HJ, GJ, PJ, HJ, GJ, and out of these various anastomosis, the most vulnerable anastomosis to leak The maximum chances of leak, again a question asked, is with PJ. The maximum chances of leak will be with PJ. Now, can you tell me what suture material are you going to use for PJ? Pancreatic ductness नहीं बनते। तो क्या सूचर यूज करें? हेपेटोजेनोस्मी के लिए वाइक्रिल, जीजे के लिए TDS. Very good. So this is what is Whipple's procedure, and the most common complication of Whipple's procedure is delayed gastric emptying. If not in your choice, then pancreatic fistula. And the most common cause of death in Whipple's procedure, again a very commonly asked question, is sepsis. Most common cause of death in Whipple's procedure is sepsis. Then we are in these patients doing palliation of symptoms. So what symptoms do we need to palliate?
Jaundice.
One is jaundice, very good. Any other symptom we may need to palliate? Two. Any other symptom we have to palliate? Pain, very good. Good. So how will you palliate jaundice? How will you relieve jaundice of this patient? Remove the obstruction. How will you relieve jaundice? दवाई देंगे, दुआ करेंगे. We will do this. What we will do? We will put what is this called? Endoscopic stenting. Endoscopic stenting. And for pain, we manage pain, right? And for goo, very good. We have two options in gastric outlet obstruction. One option is duodenal stenting. Second option, any other option you can think of? और कुछ कर सकते हैं? यहाँ पे ऑब्स्ट्रक्शन है, सोचो जरा. यहाँ ऑब्स्ट्रक्शन हो रही है, ड्यूोडेनम पे प्रेशर आ रहा है, ये स्टमक है, एंडोस्कोप से बेलून तो स्टेंटिंग कर तो दी. स्टेंटिंग के अलावा क्या ऑप्शन है? क्या ये कर सकते हैं? इससे काम बन जाएगा, कुछ बन जाएगा ना. So what is this called? Gastrojejunoscopy. So this is how we are going to palliate jaundice and gastric outlet obstruction in a patient of carcinoma pancreas. Understood now? आता है इनको? तुम्हारे एग्जाम में अब मेनली क्वेश्चंस आएंगे ही मैनेजमेंट पे और अप्रोच पे. They expect you to know how will you approach in a given situation and how you manage. They will not expect you to know the intricacy of management though, but they will expect you to know the overview of management. Okay, can we go ahead? So this was about. चलें आगे. क्या चीज? तो क्या करें? छोड़ दे मरने के लिए? एंजॉय कैसे करेगा? जॉन्डिस हो रखा है, खा भी नहीं पा रहा, तो एंजॉय क्या करेगा? ये थोड़ा एंजॉय तो करवाओ इससे, इससे तो एंजॉय करेगा। Prognosis in a CA pancreas is never good. It's a very aggressive malignancy and the prognosis is very bad. Even with a Whipple's procedure, the survival is it's not very good. Okay, now coming on to, then comes endocrine neoplasm of pancreas. Endocrine neoplasm of pancreas. In endocrine neoplasm of pancreas, we have functioning endocrine neoplasm, we have non-functional tumor. We have functioning tumors, we have non-functional tumors. Which is more common? Which is more common? As per the latest, non-functional tumors of the pancreas are more common than functional. Please note, this is the latest. In a functioning tumors of the pancreas, we have insulinoma, we have gastrinoma, we have glucagonoma, we have viacoma, we have somatostatinoma. These are the various functioning tumors of the pancreas. Now, can you tell me which is the most common functioning tumor of the pancreas? Most common is insulinoma. Now, let's start with insulinoma. Let's start with insulinoma. Now, insulinoma is the most common functioning tumor of the pancreas. Insulinoma is the most common functioning tumor of the pancreas. It is slow growing. 85% of the time, it is benign. 85% of the time, it is benign. And it is arising from the beta cells of Langerhans. It is arising from the beta cells of Langerhans. So it is an insulin secreting tumor. It is a insulin secreting tumor. So what do you expect? How will this patient is going to come to you? Patient comes to us with symptoms of hypoglycemia. And in these symptoms of hypoglycemia, again a very important point, most common symptom these patients have is palpitation. And they also have hyperphagia. They also have hyperphagia, important point. And in a patient of insulinoma, there can be a triad also. What is that triad called? Whipple's triad. That triad is called Whipple's triad. What is this Whipple's triad? Whipple's triad is patient having signs and symptoms of hypoglycemia. Second, the blood glucose level at the time of these attacks is less than 50 milligram per deciliter, and relief of symptoms relief of symptoms on taking glucose. Any patient comes to you with this kind of a feature, Whipple's triad, one should always suspect insulinoma, right? And the investigation of choice, very commonly asked question again, for insulinoma is prolonged fasting insulin level. Investigation of choice for insulinoma is prolonged fasting insulin level. Now, once you have diagnosed insulinoma, it is important for us to understand. एक बार हमने इससे diagnose कर लिया insulinoma, then we are supposed to locate where in pancreas this tumor is. So, the localization study of choice for insulinoma, if asked, it will be intraoperative. This intraoperative word is important. Intraoperative ultrasound. If intraoperative ultrasound is intraoperative ultrasound will not be the answer. It has to be intraoperative minded. So if intraoperative ultrasound is not in the choice, then it will be endoscopic ultrasound. Then it will be endoscopic ultrasound. And the treatment of choice for insulinoma is enucleation. Treatment of choice for insulinoma is enucleation. चले आगे. Then comes gastrinoma. Gastrinoma is a tumor arising from G cells secreting gastrin. It can be sporadic. It can be familial. It can be sporadic. It can be familial. Sporadic gastrinoma is more common than familial. Once it is familial, can anyone tell me which familial syndrome it is associated with? Okay. Gastrinoma itself is called Zollinger-Ellison syndrome. It is very good. It is associated with MEN1. It is associated with MEN1, multiple endocrine neoplasia 1. What are the 3 P's in MEN1? Very good. Pituitary tumor, obviously pancreatic tumor. What the third P is? Parathyroid. Good. These are the 3 tumors these patients have. Now, what is the most common pancreatic tumor in MEN1? The most common pancreatic tumor as per the latest is insulinoma. But please be careful about it. This is the latest here. If you are asked what is the most common enteropancreatic tumor with MEN1, enteropancreatic if they specify, then the answer will be then the answer will be gastrinoma. If they ask you what is the most common pancreatic tumor with men1, it is insulinoma. Please be careful about it. Now, gastrinoma can arise from duodenum, can arise from pancreas. And very important point to note, gastrinoma more commonly arises from duodenum. Gastrinoma more commonly arises from duodenum. Important point. Okay, and this gastrinoma usually arises from a triangle. What is that triangle? That triangle is called gastrinoma triangle, or what is another name for that? It is not Pasaros, it is Saros triangle. It is Saros triangle. So what is this Saros triangle? This is a very commonly asked question in our exam. This Saros triangle is formed by junction of cystic duct with CBD, junction of cystic duct with CBD, second and third part of duodenum, second and third part of duodenum, and body and neck of pancreas. So if this is second and third part of duodenum, this is pancreas, and this is the junction of cystic duct with the CBD. This is the triangle. Right? Okay. Now, what is the most common presentation of a patient of gastrinoma? The most common presentation of a patient of gastrinoma is pain abdomen with diarrhea. Important. Most common presentation of gastrinoma is pain abdomen with diarrhea. Now, please, it is important for us to know, not this gastrinoma or Zollinger-Ellison syndrome is not a common tumor, right? It's a very rare tumor. So, any patient coming to us with pain abdomen and diarrhea, we just can't start suspecting gastrinoma, because gastrinoma is not a common tumor. So, we should know that when to suspect gastrinoma. So, they can give you these profiles of the patients, and they can expect you that what will you do as a next investigation. So what profile of the patient will trigger you to think about a Zollinger-Ellison syndrome? So if you are told that the patient has a intractable peptic ulcer disease, and you are asked what will be your next step, before we do a surgery, you all know that in intractable peptic ulcer disease, we are supposed to offer surgery. Do you know that or no? Yes or no? We talked about two indications of surgery are there: complications and intractable peptic ulcer disease. So whenever intractable peptic ulcer disease is there, we know that we should be offering a surgery. But before we offer surgery, we should be ruling out gastrinoma. How will we rule out gastrinoma? You will come to know. Right? Second, when there are multiple sites, peptic ulcers told to you. You are told that the patient has a multiple sites ulcer, or you are told to you that there is an unusual site of peptic ulcer. What is the usual site of peptic ulcer? What is the most common site of gastric ulcer? Most common site of gastric ulcer. Gastric ulcer. Lesser curve at incisura angularis. Lesser curve at incisura angularis. लिख रहे हैं छोटी छोटी खुशी है. Lesser curve incisura angularis. And what is the most common site of duodenal ulcer? First part of duodenum. So if the ulcer is not on these sides, any other sides, it is unusual site. And fourth is peptic ulcer disease with diarrhea. So any patient if comes to you with a peptic ulcer disease with diarrhea, we should think of, but then they are writing the answer. This is first time I noticed those who are on online, but how will I see? ऐसे ही अच्छा, but probably they don't know that I can't see, है ना? But then कैसे? So peptic ulcer disease with diarrhea, if the patient presents to, we should be suspecting. Now, this is a question to the online people who are there. Are you understanding or not? पता नहीं, मैं देख लेता हूँ क्या कहते हैं. I hope you guys are understanding.
Yes, sir. Yes, sir. Yes, 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 sir.
Okay, good. So, okay. So, if any such patient comes to us, we should be thinking of gastinoma. So, whenever we are thinking of a gastinoma, what investigation we should be doing? The investigation of choice for gastinoma is fasting, serum, gastrin level. Fasting, serum, gastrin level. If the fasting serum gastrin level is more than 1000 picogram per ml, our normal होता है 150. The normal level of gastrin is 150 picogram per ml. But if any patient has a fasting serum gastrin level of more than this, your diagnosis of gastinoma is confirmed. Your diagnosis of gastinoma is confirmed, right? But sometimes the level comes between 150 to 1000 picogram per ml. So they can ask you that you have done a fasting serum gastrin level and the gastrin level of the patient has come to 600, say for example. So what will be your next line of investigation? The next line of investigation in such patient is secretin stimulation test. We are supposed to do a secretin stimulation. We can do histamine infusion also. We can do calcium infusion test also. These are the various tests which are supposed to be done once the level of the gastrin comes in between that, in these two values. But out of these three tests, again a question asked, the most sensitive test is secretin stimulation test. Secretin stimulation test. Now once you have diagnosed it, now please understand, you have now diagnosed biochemically that the patient has gastinoma. आपको biochemically पता लग गया कि patient को gastinoma है. Calcium infusion, histamine infusion, and secretin stimulation. Now you know biochemically that the patient has gastinoma. Now we are supposed to locate where this tumor is. Is it in the duodenum or is it in the pancreas? So now we are supposed to do a localization. So localization, study of choice. The localization study of choice in gastroenoma is SRS, not SRK. SRS. सोमैटो बहुत परेशान है बेचारा. Somatostatin receptor scintigraphy. वैसे इतना कोकेन किसी के पास भी मिलेगा. गौतम नगर में घूम मिल जाएगा. People are no. What I there is something else to that actually. Something more to it. So somatostatin receptor scintigraphy. This is the localization study of choice. But if it is not in the choice, then it is endoscopic ultrasound. Right? And the treatment of choice for gastroenoma is wide excision, as per the latest now, with lymph node dissection. But in case of a familial gastroenoma, please be careful about it. In case of a familial gastroenoma, your answer should be proton pump inhibitors. If not in the choice, then HSV. What is HSV? What is HSV? सुना सुना लग रहा है? हाँ? अर्पिस? So online people are helping you actually. Highly selective begotten. So these are the things we need to know in endocrine neoplasm of pancreas. So this is all about our discussion on pancreas. Any question? चले आगे. Then comes familial वाले का treatment है proton pump inhibitors. If not there in your choice, then highly selective begotten. Then comes intestine. Let's talk about intestine. Now, in intestine, let us first start with acute intestinal obstruction. Let us talk about acute intestinal obstruction. In acute intestinal obstruction, first of all, there can be two kinds of obstructions. Dynamic obstruction, which is also called mechanical obstruction. We have adynamic obstruction also, which is also called non-mechanical. Dynamic or mechanical, adynamic or non-mechanical. Now, let us first talk about this dynamic obstruction. Let's understand what is this dynamic obstruction. See, if this is a lumen of the intestine, as the name suggests, in mechanical obstruction, there is some mechanical cause obstructing the lumen of the intestine. Now, what mechanical cause you can think of? Can anybody tell me that what all mechanical causes you can think of in a patient leading to acute obstruction? Very good, online guys. Shubham, very good. Fecalith, good. Very good. Fecalith is one. Tumor is one, as you rightly said. Any other? Perforation will not lead to obstruction. Perforation will lead to peritonitis. अभी हमने एक कंडीशन डिस्कस करी थी, हमने डिस्कस कर ली, पता ही नहीं, हम करेंगे तो हमने कोई कंडीशन डिस्कस करी है अभी तक अक्यूट इंटेस्टिनल ऑब्स्ट्रक्शन की? नहीं करी। What is that called? इतना बता दिया सर, बहुत है। Gallstone ileus. Gallstone ileus. So that means in mechanical cause, please understand this. In mechanical cause, there can be a cause present inside the lumen of the intestine, like gallstone ileus. There was a stone obstructing the lumen. Like she already said, fecalith, obstructing the lumen is something which is present inside the lumen, right? So that means a mechanical cause can be present inside the lumen. As Shubham said, that there can be a tumor. So there can be a tumor arising from the wall of the intestine, obstructing the lumen. So there can be a problem inside the lumen. There can be problem arising from the wall, and there can be something compressing the lumen of the intestine from outside also, right? So any condition you can think of which is obstructing the lumen of the intestine from outside. Pregnancy, yes, that can be there. Not usually cause, but yes, can cause. Gravid uterus can compress. Annular pancreas, very good. Very good. Who said that? Monica. Good. Then there can be a carcinoma cervix impinging over the rectum, and there can be adhesions. Post-operative adhesions can also obstruct the lumen of the intestine from outside. So what I am trying to convey through this is that in acute intestinal obstruction, the patient has, in a mechanical type of obstruction, there is some dynamic cause which can be either inside the lumen or arising from the wall or compressing the lumen from outside. So there is always some cause which is obstructing the lumen. But this obstruction to the lumen is such that the complete obliteration of the lumen is happening. So once the complete obliteration of the lumen happens, the patient develops an acute obstruction. If the obliteration of the lumen, imagine, happens like this, the patient won't develop an acute obstruction, patient will develop a chronic obstruction. So we are talking about an acute obstruction. So acute obstruction in a mechanical cause, there is some mechanical thing obstructing the lumen of the intestine completely, either from inside or from the wall or from outside. So this mechanical cause can obstruct small intestine. This mechanical cause can obstruct large intestine also. Can you tell me, out of small and large acute intestinal obstruction, which will be more common? Two choices. Small intestinal obstruction is more common than a large, right? Now, how does a patient of acute intestinal obstruction presents? There are four cardinal symptoms of acute intestinal obstruction. What are those symptoms? Pain, abdomen. And what is the nature of that pain? Colicky. So patient will come to you with pain abdomen, which is colicky in nature. Patient can have vomiting. Patient can have distension of abdomen. Patient can have obstipation also. What is obstipation? No feces, no fetus. Flatus. No feces, no flatus. Now, if you can recall, please, if you can recall, you can appreciate that these were the symptoms of peritonitis also. The only difference was the pain. There was continuous stabbing type of pain. Continuous stabbing type of pain. So it is very difficult on the basis of the symptoms to differentiate obstruction from peritonitis. We can differentiate obstruction from peritonitis only when we have a examination findings with us. So what on examination you will find? Let's see. You will find distended abdomen. The abdomen you will find distended. You will also find the abdomen tympanic. Why tympanic note is there on abdomen? Because the proximal bowel will distend with air. You are swallowing air with every breath you are taking. So because of that, the proximal bowel will distend and on percussion will give a tympanic note. Then what will be the status of the bowel sounds? Heard. Okay. What will you hear in that bowel sound? Vowel sounds will be normal or increased. There is an obstruction. Imagine there's a gallstone IBS obstructing the lumen like this. So what the bowel tries to do, initially the bowel will try to get past this obstruction. So increased peristalsis will happen initially. So bowel sounds will be increased initially. But over a period of time, if the obstruction is so pronounced, the peristalsis gets tired or weakened, and over a period of time, the peristalsis will be absent. So what does that mean? Absent bowel sounds in a mechanical obstruction. This is a very important observation. Absent bowel sounds in a mechanical obstruction is a feature of it's a late feature. And late anything if happens in obstruction, please try to understand. एक mechanical obstruction है, proximal bowel distend हो रही है, 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 हो रही है, और हो रही है, और हो रही है. इसके बाद क्या होगा? The point will come when it will perforate, but that will happen after some time. So absent bowel sounds in a patient of acute intestinal obstruction is a bad sign, because it happens in the late phase, and in late phase patient can anytime perforates, and once perforates, what will happen? Peritonitis. So in any patient of acute intestinal obstruction, this is a basis of understanding the management of obstruction. In any patient of acute intestinal obstruction, we don't want the peritonitis to set in. We don't want peritonitis to set in. So that means we have to diagnose obstruction early. If we diagnose obstruction early, then only we can avoid the peritonitis which may happen. So we have to diagnose obstruction early, and we have to manage obstruction early also. And in obstruction, please understand this. In any patient of acute intestinal, if you can recall, I told you in gallstone ileus that we'll be talking about the intestinal obstruction and how the approach goes in obstruction when we talk about intestine, right? So we are talking about that at this moment. So in any patient of acute intestinal obstruction, please understand this point. In any patient of acute intestinal obstruction, we just want to know that whether it's a mechanical obstruction or it's a adynamic obstruction. Because once it's a mechanical obstruction, whatever that mechanical cause may be, we have to remove that cause. We have to remove that cause. There is no other way about it. So we are just not bothered to know what that mechanical cause is, because whatever that mechanical cause may be, we have to remove it. So the only thing required in a patient of acute intestinal obstruction for us is to know whether it's a dynamic obstruction or an adynamic. So how will we know that it's a dynamic or an adynamic obstruction? We will try to understand in this discussion. Okay, now, before we understand that, we all know now that the most common type of acute intestinal obstruction is a small intestinal obstruction. And the most common cause of acute small intestinal obstruction is post-operative adhesions. The most common cause of acute intestinal obstruction, small intestinal, it is adhesion. Now, what is this adhesions? You will be provided a profile of the patient and you have to make out whether it's an adhesive obstruction or not. You will be told that the patient is coming to you with these features. How will you know that the patient has an obstruction due to adhesions? You will be provided that in past, the patient has a history, the operation done on abdomen. So whenever we do surgery in abdomen, you should know this point. जब भी हम abdomen में surgery करते हैं, कोई भी surgery करें, when we handle bowel, the inflammation happens in the bowel, and because of handling of the bowel gets adhered to each other, which is called post-operative adhesion. And these adhesions may later on can lead to obstruction also. Okay, so most common cause of acute small bowel obstruction is post-operative adhesion, and the most common cause of acute large bowel obstruction is malignancy. So if I ask you, what is the most common cause of acute intestinal obstruction, dynamic type, what will that be? Post-operative adhesive obstruction. Another question, because you should know the clinical understanding of the subject topic. Can you make out on the basis of patient's presentation whether the patient has a small bowel obstruction, acute type, or a large bowel? Yes or no, or I don't know. Yes or no? Answer is yes. So what clinical profile of the patient will make you think of a large bowel obstruction? What clinical profile of the patient makes you think a small bowel obstruction? Let's see. If in a given question you are told that the pain abdomen of the patient, which is colicky type, is central, think of a small bowel obstruction. If it is told in flanks, think of a large bowel obstruction. Vomiting in small bowel obstruction is an early feature, while vomiting in a large bowel obstruction is a late feature. Now, this vomiting is a very important clue. With vomiting, you can make out many things. With vomiting, we can make out many things. How? Imagine a patient comes to you with a vomiting which is non-bilious. What does that suggest? There is no bile coming in the vomiting. It means the obstruction is proximal to ampulla of Vater. If the patient is vomiting, which doesn't have a bile in it, it means the obstruction is proximal to ampulla of Vater. If the patient comes to you with a bilious vomiting, it suggests that the obstruction is distal to ampulla of Vater. So presence of bile and absence of bile is a very important thing. Now, in case of a large bowel obstruction, now you tell me, in case of large bowel obstruction, whether there will be bile in the vomitus or not. Think about it. Jaldi nahi hai koi. होगा कि नहीं होगा? Yes or no? नहीं. शुभम कह रहा है होगा. अगर लार्ज बाउल में ऑब्स्ट्रक्शन है तो ऑब्स्ट्रक्शन लार्ज बाउल से शुरू होगा, धीरे 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 ऊपर चलता जाएगा, प्रॉक्सिमल बाउल तक पहुंचेगा, ड्यूodenum तक पहुंचेगा, डिस्टेंशन और स्टमक में पहुंचेगा. तो क्या बाइल इसके पहले है नहीं? तो पेशेंट इनिशियली of a large bowel obstruction will have a bile in the vomitus, but subsequently the patient will have a fecal matter coming in the vomitus. So initially bile and then fecal matter coming in the vomitus is suggestive of a large bowel obstruction. Then distension. Distension in a small bowel obstruction will be central. Distension in a large bowel obstruction will be on the flanks. Obstipation is an early feature. Obstipation is a late feature in case of a small bowel obstruction. Now, correct me if I'm wrong. Can I say here that acute intestinal obstruction is an acute infective GI condition? Yes or no? Yes. Why it is infective? It is acute because name is there as acute and it's a GI condition also. But why infective? Who will tell me? Why gut bacteria are causing a problem here? Because very good, there is a stagnation, and I made you understand that whenever the contents anywhere of the body get stagnant, there will be proliferation of bacteria and there will be infection. So it's an acute infective GI condition. Very good. So what will be your first line of management? Nil perorally. Here, in a patient of acute intestinal obstruction, it's an acute infective GI condition. We have to follow the same protocol, but along with keeping patient nil perorally here, we are supposed to put in a Riles tube. We should do a Riles tube aspiration because we want to deflate the proximal bowel, whichever is distended. And along with this, we will start IV fluids, IV antibiotics, and IV anti-inflammatory drugs. And simultaneously, we have to investigate and find out whether it's a dynamic obstruction or a adynamic obstruction. So how will we know? The first investigation you are going to do will be X-ray, abdomen, erect, and supine. X-ray, abdomen, erect, and supine. Now, out of supine and erect X-ray, important point to note, in erect X-ray, we see air fluid levels. In erect X-ray, we see air fluid levels, and normally, you should know, normally, there are 3 to 5 air fluid levels. In a normal individuals, on erect X-ray, we get normally 3 to 5 air fluid levels. Supine X-ray tells us about the site of obstruction. Supine X-ray tells us about the site of obstruction, and it also helps in diagnosing. It also helps in diagnosing obstruction early. So, if you are asked out of erect and supine X-ray, which X-ray is a better X-ray? Answer in your MCQ source is not right. Supine X-ray is a better X-ray than erect X-ray. While the investigation of choice, for acute intestinal obstruction is CT scan. Investigation of choice for acute intestinal obstruction is CT scan, right? And the treatment of acute intestinal obstruction is immediate. Acute dynamic obstruction is immediate exploratory laparotomy. Because whatever that mechanical cause may be, we have to remove it. So in any patient of acute dynamic obstruction, we should be operating early. Except, please note this point, there is only one type of dynamic obstruction. There is only one type of dynamic obstruction where you should wait, and that is called watchful expectancy. Watchful expectancy. And what that type of acute dynamic obstruction, where we are going to offer a expectant treatment, that is post-operative adhesive obstruction is the only type of acute dynamic obstruction where we should wait, and we are not going to wait till eternity. We should wait for 48 to 72 hours with this conservative treatment which we have already started. Most of these patients of post-operative adhesive obstruction resolves with a conservative treatment itself. Most of the patients of acute adhesive obstruction resolves with a conservative management. Okay, now, very important discussion. You will be checked on this. You may be asked to find out about the site of obstruction by seeing an X-ray. So, how to interpret X-ray abdomen and find out the site of obstruction? Important discussion. So, for that, to know, we have to first know how a normal X-ray looks like. When we know what is normal, then only we can understand what is abnormal. Okay. Now, you all know this. If this is abdomen, you all know this, that some part of the intestine in abdomen is completely peritoneal. Some part of the intestine is completely retroperitoneal. Some part of the intestine is partly peritoneal, partly retroperitoneal. We know that. And you also know at the same time that part of the intestine which is completely peritoneal is mobile. And the part of the intestine which is retroperitoneal or which is partly peritoneal or partly retroperitoneal is going to be fixed. So there are some part of the bowel which is going to be fixed. There is some part of the bowel which is going to be mobile. So there is stomach which is partly peritoneal, partly retroperitoneal. So it will be fixed. Similarly, duodenum is completely retroperitoneal. It is again going to be fixed. Then jejunum and ileum is completely peritoneal, so it will be mobile. And then on the right side, there is a ascending colon. On the left side, there is a descending colon, and these are again having an attachment with them, so they are again going to be fixed. This transverse colon is completely peritoneal, so it will be mobile, right? And these ascending colon and the descending colon are called the pillars of the abdominal cavity. Why they are called pillars? Because they are always fixed. They are always going to be there because they are fixed. So they are called pillars of the abdominal cavity. Now, how the normal X-ray look like? Let's understand that. I'll show you also, but before that, our eyes can only see what our mind knows. So let's see that how the normal X-ray look like and understand that first. On X-ray, you all know that bowel on X-ray, the air is black. Yes, and fluid is white. Okay, and you also know that wall of the intestine is made up of cells, and cells have fluid in them, right? So every bowel lumen on X-ray has certain features. In jejunum, if this is a jejunum, in jejunum, you will get two parallel white lines. In a normal individual, when you are seeing a supine X-ray, in the jejunum will have a two parallel white lines and having wide concentric rings inside. So when you see two parallel white lines with concentric white rings inside which are at equal distance, you can make out that you are seeing a jejunum. So it is jejunum. So whenever you see two parallel white lines with concentric ring inside, you are seeing jejunum. And whenever you see two parallel white lines with no feature inside, if you see two parallel white lines with no feature inside, nothing, just two parallel white lines, it means you are seeing is featureless. And these concentric rings which you are seeing in jejunum are called volvulae conniventes. These concentric white lines, white rings inside the jejunum are called volvulae conniventes. And this colon, the colon on normal, in a normal, colon will have two parallel white lines with partial irregularly placed white lines inside. Colon has two parallel white lines with partial lines inside which are irregularly placed. And these partial lines which you are seeing are called ostrations. So when you see a normal individual's supine X-ray, when you see a normal individual's supine X-ray, in a normal individual, you should always first see the pillars. The pillars are fixed, so you will get two parallel white lines with irregularly placed partial lines inside. Okay, and You will also see some of the loops with two parallel white lines with concentric rings inside. You will also see some of the loops with two parallel white lines with nothing inside. So in a normal individual, you will see the pillars also, you will see a concentric ring loops also, and you will see the featureless loop also. Now imagine, please understand this. Now imagine a patient had a gallstone ileus. Patient had a gallstone ileus and suddenly the stone has come and obstructed terminal ileum. Suddenly the stone has come and obstructed the terminal ileum. Now once this obstruction happens, please appreciate this. Once this obstruction happens, this is a proximal bowel, this is a distal bowel. Agreed? This imagine is a proximal bowel and this is a distal bowel. Now, this patient who has a acute intestinal obstruction due to gallstone, now the content are not going to go forward because they are blocked. Now, this patient will still keep taking breath. So when he's taking breath, he is swallowing air. So air inside this bowel proximal bowel keeps building up, while in the distal bowel, whatever air was there, the moment this patient passes flatus, that air will go away, and moment the air goes away, the loop collapses. जैसे air निकल गई, why were we seeing the features inside the bowel? Because there was an air inside. Now, moment the obstruction happens, the distal part of the bowel, the moment patient passes flatus, the air goes off. So now, once the distal loop is collapsed, obviously you will not be able to see the features inside, right? So in a supine X-ray of a patient of gallstone ileus, in a supine X-ray of a patient of gallstone ileus, you will be able to see the concentric ring loops. You will be able to see the featureless loops, but you will not be able to see the pillar on the right side and the pillar on the left side. So if you are seeing a concentric ring loop and the featureless loop, but not seeing a pillar, it means the obstruction is where? In the terminal ileum. In the terminal ileum, because you could not see the pillar on right side, you could not see the pillar on the left side. Right? Now imagine the patient has an obstruction here. Imagine your patient has obstruction here. Your patient has obstruction here. In the jejunum, your patient has obstruction in the jejunum. You will not be able to see the pillar also. You will not be able to see the featureless loop also. What will you see only? The concentric ring loops only. So when you are seeing only concentric ring loops, it means where is obstruction? At the jejunal level. So this is what you get in a supine X-ray. In a jejunal obstruction, you will not be able to see the pillars on the right or left side. You will not be able to see the featureless loops also, but you will only be able to see the concentric ring loops. Now, supine X-ray we have understood. Supine X-ray we understood probably, right? now look at this X-ray and tell me where is the obstruction.
Right.
क्या है? पिलर है, कंसेंट्रिक रिंग लूप दिख रहे हैं, दिख रहे हैं, फीचरलेस लूप दिख रहे हैं, नहीं दिख रहे, अब दिखेंगे। दिख गया, दिखा, ये तो दिख रहा है, क्या है अंदर, कुछ है नहीं है, ये क्या ग्रुप है, ये हीलियम है, सो फीचरलेस लूप भी दिखा और कंसेंट्रिक लूप भी दिखा, तो मतलब कि ऑब्स्ट्रक्शन कहाँ है और पिलर नहीं दिखा, तो इसका मतलब ऑब्स्ट्रक्शन इज एट अ टर्मिनल आइडियल लेवल। समझ आया? सो दिस इज हाउ वी मेक आउट that the patient has a obstruction at a terminal ileal level by seeing the concentric ring and a featureless loop also. Let me see if I have the image. Now in a erect X-ray हम क्या कर रहे हैं? In what erect X-ray is helping us out? Please understand this. What erect X-ray is helping us out? Erect X-ray में हम air fluid levels देखते हैं. Erect X-ray में what we see air fluid level. What do you mean by air fluid levels? Air fluid level का मतलब होता है कि अब क्या होगा? अब क्या होगा? Obstruction हो गया, तो contents are not moving forward. So over a period of time, what will happen with the gravity? जहां पे जो food है will get stagnant like this and start settling down, and the air will ascend up. So air fluid levels will come. So जितना distal obstruction होगा, please understand this point. जितना distal obstruction होगा, उतना ज्यादा कंटेंट बावल में होगा, उतनी ज्यादा लंबी बावल होगी, सो उतने ज्यादा एयर फ्लूइड लेवल्स मिलेंगे. मोर डिस्टल इज ऑब्स्ट्रक्शन, more will be the number of air fluid levels. So in a terminal ileal obstruction, please understand this point. In a terminal ileal obstruction, since the terminal ileum is quite a distal part of the bowel and there is quite a lengthy bowel in front of terminal ileum, so you will get multiple air fluid levels. If the obstruction is in the left colon, if the obstruction is in the left colon, the number of air fluid levels will be more than the number in the terminal ileal obstruction, right? In a terminal ileal obstruction, जितने number of air fluid levels थे, उससे ज़्यादा air fluid levels आपको colonic obstruction में मिलेंगे, और jejunal obstruction में number of air fluid levels will be lesser than what you get it in a terminal ileal or a colonic obstruction. So supine X-ray की finding को हम erect X-ray की finding से corroborate करते हैं. Supine X-ray से हम site of obstruction पता लगाते हैं और उस site of obstruction से हम expect करते हैं कि erect film में कितने air fluid levels होने चाहिए. So अगर आपके air fluid levels आप terminal ileum suspect कर रहे हो और आपको multiple air fluid levels मिले, तो your suspicion of a terminal ileal obstruction is right. Similarly, if you are expecting a jejunal obstruction on the basis of supine X-ray, if you get a lesser number of air fluid levels in comparison to what you get in a terminal ileal obstruction, your suspicion of a jejunal obstruction is also right. So erect X-ray is corroborating with a supine X-ray, but supine X-ray is always a better X-ray than a erect. So how air fluid levels look like? They look like this. This is how air fluid levels look like. Multiple lines दिख रही हैं? These are the air fluid levels. So erect film is there to corroborate with the supine film, but supine film is always better than erect film. So this is how you will diagnose. समझ आया कि नहीं? पक्का? इसमें नहीं पता लगेगा. That you will come to know only in supine X-ray, because in this you will only get a air fluid level. In supine X-ray, you will come to know whether you're seeing a jejunum or ileum or a colon. Let me, I should have that image. Wait. Yes, look at this. अब इस इमेज को देख के बताओ कि कहां पे ऑब्स्ट्रक्शन. राइट पिलर दिख रहा है? नहीं दिख रहा है? दिख रहा है? लेफ्ट पिलर दिख रहा है? नहीं दिख रहा है? आ जाएगा यहाँ पे कॉपी करने पे. इंसर्ट में पिक्चर तो कोई नहीं रहा. Okay, I'll show you. Then so there is a pillar on the left side which is suddenly collapsing there. Can't you make out? Yes or no? So this is a patient who has a left colonic obstruction. Understood? पक्का? दिखा क्या नहीं? Everyone? Understood now? Sure? ठीक है. तो अगर हमें देखो जहां तक का हमें बावल दिख गया, हमें फीचरलेस लूप दिख गया, तो इसका मतलब कि ऑब्स्ट्रक्शन आइलियम तक नहीं है. हमें कोलोनिक लूप दिख गया, तो इसका मतलब क्योंकि एयर वहां तक पहुंच गया, एयर वहां तक पहुंच गया. सो इफ वी गेट अ पिलर ऑन द राइट साइड but we don't get a pillar on the left side, what does that mean? Where is obstruction? Most likely this obstruction is either in the transverse colon or on the left colon, right? अब हमें concentric rings और featureless loops ढूंढने की जरूरत नहीं है. हमें अगर राइट साइड का पिलर मिल गया तो इसका मतलब है एयर वहां तक पहुंच गई है. एयर जेजुनम और आइलियम से तो होगी नहीं है. तो अगर हमें राइट साइड का पिलर दिख गया और लेफ्ट साइड का पिलर नहीं दिखा, भले ही हमें कंसेंट्रिक रिंग लूप और अ फीचरलेस लूप वी डोंट गेट, इट डजंट मैटर, बिकॉज up to what level the air has reached, That is the goal to find out. So if we find out air in the ileum, but we don't see a pillar on the right side, we should not be searching for a concentric ring loops, because the air has reached up to the ileum but failed to reach up to the right colon. So where is obstruction? Right. It is a terminal ileal obstruction. Understood? Everyone? पक्का? क्योंकि ये बहुत इंपॉर्टेंट एक्सरे है, ये क्वेश्चन आ सकता है. You may be asked to find out the site of obstruction on the basis of X-ray. In a patient of obstruction, we have to first see the pillar. अगर हमें pillar नहीं दिख रहा, तो या तो ये jejunal obstruction है, either it is a jejunal obstruction or it is a ileal obstruction, because it cannot be a colonic obstruction because the pillar is not seen. Okay. Now we have to see what loop are we seeing. Once we see a featureless loop, we are not going to chase the concentric ring loop, because once we got a featureless loop, means the air has reached up to the featureless loop. So it means, and the air could not reach the right colon. So that means the obstruction is in the terminal ileum. Understood? If we get a concentric ring loops, but we don't see a featureless loop and the pillar, it means the obstruction is at the jejunal level. All of you understood now? So this was about diagnosing obstruction on the basis of X-ray. Okay. Then comes adynamic obstruction. In adynamic obstruction, the most common cause of adynamic obstruction, again a question asked, is paralytic ileus. The most common cause of adynamic obstruction is paralytic ileus. As the name suggests, there is paralysis of movement. Paralytic ileus means paralysis of movement, and the most common cause of paralytic ileus is post-operative. Not post-operative adhesions, post-operative. What does post-operative means? Movement, we do surgery on the abdomen. We have to touch bowel, and movement we touch bowel, bowel is a touch me not thing. Movement you touch bowel, the bowel goes in paralysis. Over a period of time, once the surgery is over a period of time, gradually, the bowel comes out of that paralysis. The first part of this was also one of the questions. The first part of the bowel, which comes out of this paralysis, is small intestine. And then the stomach comes out of the paralysis, and then the proximal colon, and the last part of the bowel, which comes out of the paralysis, is distal colon. There was a question asked, which part of the bowel has a most pronounced ileus? Distal colon has a most pronounced ileus because it takes the maximum time to return to activity. So the most common cause of paralytic ileus is post-operative, right? Then the other common causes of paralytic ileus are electrolyte imbalance. Which electrolyte imbalance? Most common is hypokalemia. It can be hyponatremia. It can be hypomagnesemia also. The other common causes of paralytic ileus are anemia, uremia, renal colic, burns, intra-abdominal collections, MI, ureteric colic, pneumonia, pneumonitis. Now, if you look at these causes, you can see that none of them has anything to do with the bowel. But still, the bowel has decided not to move. Right? So, in paralytic ileus, there is a paralysis of movement happening because of some problem outside the bowel. Right? Now, how does this patient is going to present to us? This patient of paralytic ileus, please note this point, is going to present to us with these features again: pain abdomen, vomiting, distension, and obstipation. But very important point to notice that in this very patient of paralytic ileus causing an acute obstruction, the pain will not be colicky. The pain will be dull aching. The pain in paralytic ileus is going to be dull aching pain. Right? And on examination of these patients also there are findings. Abdomen will be distended, tympanic also, but what will be the status of bowel sound? Who will tell me? Because there is no peristalsis happening. So bowel sounds will always be absent here. But we know that absent bowel sound can also happen in a dynamic obstruction also. So just by absent bowel sound, we cannot infer that it's a paralytic ileus. So what we will do, we will start with this only. Because it's an acute obstruction, we will start with this itself, and X-ray abdomen again we are going to do. And this X-ray abdomen is going to break this shackle. This X-ray abdomen is going to diagnose whether it's a dynamic obstruction or a adynamic obstruction. How? Let's see. Please try to understand. Peristalsis of the bowel is not happening, but there is no mechanical cause obstructing the lumen. There is no mechanical cause obstructing the lumen, but peristalsis is not happening. So, because of this, what is going to happen? The contents of the bowel are not going to move forward. The contents of the bowel are not going to move forward. Wherever they are going to be there, right? They are not going to move forward. But the air, what was happening in a dynamic obstruction? The proximal bowel was distending and the distal bowel got collapsed. Why? Because the distal bowel was not receiving the air. Here, in case of paralytic ileus, there is no such problem which is obliterating the lumen. The lumen is open, right? But the peristalsis is not happening. So, with this understanding now, let's see who will answer it. What supine X-ray you will expect? What erect X-ray you expect in a patient of paralytic ileus? Normal airfold level. Erect X-ray with normal airfold level. The contents are not moving forward. Less. Okay, in supine X-ray, what kind of supine X-ray you expect? There is no luminal. So that means you will be able to see concentric group also. You will be able to see featureless group also. You will be able to see the pillars also. So the normal supine X-ray. Please, अगर नहीं समझ आ रहा तो बोलना पड़ेगा, नहीं तो मुझे समझ नहीं आएगा. So X-ray supine will be normal or not? Because there is no obliteration of the lumen by any mechanical cause. So the air passing. So supine X-ray will be normal, but the contents are not moving forward. So what will happen in erect X-ray? The air fluid levels will be normal or increased or very increased. So maximum number of air fluid levels, wherever the contents are, they are going to be stagnant. So multiple air fluid levels with normal supine X-ray is diagnostic of paralytic ileus. Bouncer तो नहीं गया, पक्का कंटेंट्स आगे नहीं जा रहे हैं, एयर को कोई प्रॉब्लम नहीं है, एयर फ्रीली जा रही है, कंटेंट आगे नहीं बढ़ रहे, तो एयर द कंटेंट जहां पे भी है वो अपनी जगह पे सेटल होंगे, एयर ऊपर असेंड करेगी इरेक्ट एक्सरे में. सो मल्टीपल एयर फ्लो लेवल्स विद नॉर्मल सुपाइन एक्सरे, इफ यू गेट, इट्स अ पैरालिटिक ileus. All of you understood? Sure. Now, what is the treatment of paralytic ileus? The treatment of paralytic ileus is treatment of the cause. Treatment of paralytic ileus is treatment of the cause. If it is pneumonitis, treat pneumonitis. If it is renal polyp, treat renal polyp. If it is hypokalemia, treat hypokalemia. Because no surgery can tell the bowel to move. Right? Surgery can only remove the obstruction. There is no obstruction, only a mechanical thing. So in adynamic obstruction, we are supposed to treat the cause. No surgery required. However, in dynamic obstruction, we have to do surgery. So the only objective we have to find out in acute intestinal obstruction is whether there is a dynamic cause or an adynamic. Because if it's adynamic cause, we have to treat that adynamic cause. No surgery required. But if it's a dynamic cause, whatever it may be, we have to do surgery. So how will we know what clue will be there in your given question in a clinical profile that you should start thinking about a paralytic ileus? You may be provided with either of these profile of the patient. And then you will be told that the patient is complaining of pain abdomen, which is dull in nature, vomiting, distension, and obstipation. And on examination, the bowel sounds are absent. So with this profile, if you have a patient coming to us with obstruction, we should think of paralytic ileus. But the confirmation of diagnosis will happen when you do X-ray. समझ आया? पक्का? All of you. So you need a break now. So let's take a break. Solid